Hello everyone and welcome to this session of Conceptual Anesthesia. We'll be talking about sedation in the ICU. And sedation in the ICU assumes great importance because of the various types of patients that we have in the ICU. You must have visited ICUs and some patients may be on the ventilator, some patients may be on the NIV, some patients may be slightly sick, some patients may be very, very sick. You will be scared to start sedation because there are hemodynamic side effects. There may be some neurological patients. There may be some patients of cardiovascular disease. So you might have to know the all the medicines that you use, including the sedative and the analgesic agents. So sedation is an induced state of reduced consciousness to which verbal contact with the patient will be maintained. So this is the ideal thing, that you want a reduced consciousness level, but the verbal contact with the patient should be maintained. And the idea is to reduce anxiety and distress and to facilitate compliance with invasive procedures such as mechanical ventilation. So sometimes you have a patient who's on ventilator, you sedate him as much so that he can just respond to your verbal commands. He is sedated and he can maybe nod or move his eyelids up and down. So before sedation is initiated, the cause of distress should be identified. Common causing critical ill patients are anxiety, pain, delirium, dyspnea, neuromuscular paralysis. And these etiologies may occur separately or in combination. So when you start sedation, what is the goal of sedation in the ICU? The patient should be comfortable. The patient should be ideally pain-free. There should be no anxiety. The patient should have amnesia, blunting the adverse autonomic and hemodynamic responses, facilitate nursing management, facilitate mechanical ventilation. He should not be as much awake to have do the self-extubation, should avoid self-extubation, reduce the oxygen consumption, and do some diagnostic procedures if required. So you have many sedative agents, and we'll be talking about them later on. But what is the characteristic of ideal sedation agents in the ICU? Lack of respiratory depression. So you want a patient who is slightly sedated, but he should not have respiratory depression, especially in a patient who is not on ventilator, who's on NIV. The patient should have analgesia, especially for post-surgery patients who are having pain at different sites of operation. The sedative agent should be rapidly in onset. Titratable means you can increase the dose or decrease the dose, and the effect should be decreased or increased simultaneously within a short elimination half time. The sedation should be there with the ease of orientation and arousability. So you use some kind of sedative agents in neurological patients, especially that the patients are sedated, but when you ask them questions, they can easily be arousable. So they should have a short contact half-life. The sedation should also be having bit of anxiolytic properties, and most importantly in critical kill patients, the sedative agent should be hemodynamically stable. So it should not depress your hemodynamic system that much that it can cause hypotension. But remember, critical ill patients are very scarily placed. They are just on the borderline. Some may be already having hemodynamic instability, and you still might have to provide them with sedation. They might be intubated. So it's a very gray zone in which you have to act, and you have to act very carefully. As an example, a young patient who is in ARDS, who is having fever, who is in pneumonia, his oxygen demand is very high, and you have put him on ventilator, and now you want to sedate him. So his sedation requirement may be high because of various reasons, because of his young age, hypermetabolism, he's having fever. So these all lead to increase in the requirement of sedative agents. So what are the challenges that you face in ICU sedation? Assessment of sedation. So you have to, how do you assess a patient who's on ventilator? So there are specific scales which I'll be talking about so that you can actually see how much sedative my patient is, how much I want him, and if you need, you can decrease or increase the sedative agents. The patient may have organ failures. So there's altered pharmacology. You might have to use the agents for a longer duration of time. So tolerance may be developing. Delayed emergence. So when you use the agent for a longer duration of time, the half-life increases, the metabolism is slowed, and there is delayed emergence even when you stop the sedative agents, and drug interactions. So you have to balance the cause of agitation, the need for sedation, and the sedative agents in your ICU. So what happens is when you give less sedations, under sedation in the ICU, The patient may still have agitation and anxiety, pain and discomfort. He might potentially displace a catheter or self extubate or cause some injury to himself. There might be patient recall. He might have cardiovascular side effects. So you have an intubated patient who reacts on the endotracheal tube and leads to hypertension, arrhythmias, myocardial ischemias. Then the patients may be over sedated. So when the patient is over sedated, there is delayed emergence. When you try to wean the patient, respiratory depression, prolonged sedation. The patient may have hypotension or bradycardia depending on the side effects of the sedative agent that are used. When the patient is on the ventilator and this prolonged ventilation because of over sedation, the patient may have muscle atrophy. The patient may not be able to prevent any pressure injuries, and delayed interaction or delayed the patient on the ventilator may lead to increased risk of complications like VAP or venous thromboembolism. Now, there's a triad of pain, agitation, and delirium for which we need agents in our critically ill patients. So, we should give some bit of analgesia, and that is taken to a separate topic as well. But here we'll be talking about just sedation, and we want to maintain light sedation. And we might need to stop sedation in between, as it said that you give spontaneous awareness trials and spontaneous breathing trials. We assess and prevent delirium, and we always want to have a calm, cooperative, comfortable patient. The family should be involved in the patient care, and the patient should have good physiotherapy and early mobility.